Hello, everyone, and welcome to the latest episode of Waypoint, the podcast from AirMed&Rescue. My guest this week is the very lovely Dr. Alex Philpott, who is neonatal clinical lead for capitalairambulance based in the UK. Welcome, Alex.
Hi, Mandy. Nice to meet you.
You too. So let's start with a little bit of your professional background, first of all. Where did you do your medical training? Where have you worked since then? That kind of thing.
Okay, so I'm a consultant neonatologist, and that's a specialist looking after preterm and sick newborn babies. And I've been doing this for about 20 years. I started my medical training a very long time ago in Cambridge and did my undergraduate training in Cambridge and then London. Decided quite early on that I wanted to be a paediatrician and then trained mainly in the South London region, apart from spending 2 years in sunny Australia in New South Wales, where at the time I was going to be a paediatric intensivist, but I was seduced by the little babies and decided when I came back to the UK that actually sick neonates, making them better was really what I wanted to do. So I came back to the UK, finished my last 2 years of training as a neonatal intensivist in London. And then after a brief spell trying to do some research, I went off to Brighton to be a locum consultant and then made my way up the country. I was going to say about 15 or 16 years ago now, to be a consultant in the West Midlands. I was a sort of a general neonatal consultant for 4 or 5 years and then moved into neonatal transport in the West Midlands, and I've been in post as the lead for a neonatal transport service since then. But the fact that I've always been involved in transport, it excites me, and hence being involved with not just road transfer but air transfer makes me sort of really, really excited, and hence this is where I am working with Capital as their neonatal lead. And I think that's really me in a nutshell, where I've been and where I am now.
I mean, that's a pretty comprehensive nutshell. You've definitely been all over and seen lots of different methods of working and been in the industry for a long time. I mean, initially, you say you were drawn to working with the neonates. What do you think it was? Was it the challenge of working with the really tiny babies? I mean, it's so different with everything being so small and they're so vulnerable.
Yeah, it's really, really interesting because it's when we think about neonates, we always think about the tinies, but it isn't just the tinies. We've actually made such huge advances in neonatal medicine. We are now keeping babies alive who were born with very, very complex diseases and complex challenges, and I think really that's it. There are these massive different ends of the spectrum, but neonates has everything. We look after hearts, we look after lungs, we look after brains. We are the true generalists, and actually if we get it right, you're getting a baby right for the rest of their lives. You're making a difference for them and their families. And I'm not saying it's a better speciality than any other form of medicine.
Oh, heaven forbid. We're not making preferences. No way.
But just, I'm setting up, if we can actually make that baby, that preterm or that baby with complex disease better, you're looking at a lifespan of 80 years, 90 years, maybe even further. But the other thing is that even those babies that we know are not going to be with us for a long time, perhaps because they are born very preterm or because they've got such complex illnesses, if we can ensure that their quality of life and their family's quality of life are the best sort of quality of life possible, the memories they can make for those families will live on with them forever. So that's why I am so passionate about getting it right for our babies and our families, because it makes such a difference.
I mean, on the very sad flip side of it, you can't save everyone, and I think, is it more heartbreaking working with neonates when it doesn't work as opposed to working with maybe sort of senior patients?
Yeah, it can be absolutely devastating and heartbreaking. And managing with the parents, managing with
Yeah.
teams, my staff who've been working, looking after these babies, we always try our hardest. But I think the most important things are knowing that we've done everything we can, and that every baby has had the opportunity to get that high quality care. And then when we make a decision that perhaps actually prolongation of life is not something that we can offer and isn't the right thing, making sure that death is a good quality, that there is support in place, that memories can be made, that families can spend time with their baby. And I think that's an absolute honour to be able to make sure that whatever care we provide is the right quality of care, the highest standard of care, because as I said, those memories will stay with those families forever.
Yeah, that's an amazing way of looking at it, because I think that, the mental health of healthcare workers, especially those on the front line, particularly, it's come a lot more into the sort of general conversation now of, well, everybody's mental health is much more top of mind. But I think for healthcare workers, it's especially important. So what do you do, and what does Capital do to make sure that they're looking after their healthcare staff that might have to deal with traumatic cases, whether pediatric or any other
Yeah.
clinical case?
I think we have an open culture. We
Yeah.
can talk to each other. And I think that's really, really important. We are aware that different people will react in different ways. And sometimes it's unexpected, but always being able to talk about that and making sure there
Yeah.
is the right person and escalating that support to provide psychological support if
Yeah.
needed. But it's making it's that, and it should come through all areas of sort of medical and health professional. It's saying it is okay to be sad, as long as
Yeah.
you know you have delivered the best possible care. It is okay to say, I'm unhappy or I'm scared, I need to talk. And
Yeah.
by doing that, we can then move forward. It's when we can't talk about things, when there isn't somebody to talk to, or where a barrier has been put up, that's when problems start. And we want all of our staff to be able to go into the next mission and the next mission and the next mission without any blocks or barriers. And that's part of my responsibility to be able to do that.
Yeah. It is a responsibility. So having that open culture and that ability to approach a senior member of staff is so, so important.
Yeah, absolutely.
Okay, so moving on from that side of it, so back to you and your experience. Capital Air Ambulance is relatively new for you, but it's not your first time in the air medical field. So where did you start?
I think probably like a lot of my colleagues, the other side of the world.
Hmm?
So, as I said earlier, I went across to Sydney, New South Wales,
Yeah.
20 years ago, which is really, really mad because it feels like it was just yesterday. I think part of the draw was possibly the lifestyle and the weather, but the big draw really was to be able to go and do transfers in a way that weren't really available in the UK and Europe at the time. So the air transfers. So I worked with the New South Wales Nets team. And for those of you who, people who are not aware of the way that New South Wales looks, you have a big centre, Sydney, with lots and lots of hospitals clustered around, but then you have lots and lots of little hospitals in the middle of nowhere. And actually going by road from one hospital to another, it would take forever. So New South Wales was set up beautifully, their air transfers, with both rotary wings, so helicopters, and fixed wings. So when a call came in from a referring centre to say, we've got a sick baby or a sick child, because I was doing paediatrics at the time as well, and we need to get them to a centre where they can continue their care, we'd have to try and work out where they were, how to get there. So thinking about distance, what's the most appropriate way to go. And, even it was interesting that gridlock, Sydney in rush hour can be gridlocked. And even though you may only be going a very short period of time, you may actually decide that actually going by helicopter is the right way to go, because you can go up, you can come back down quite quickly. There are lots of playing fields in Sydney as well, even in the centre, and landing on playing fields. It just used to be beautiful. The school children would come out and watch as he landed on their school playing field. Or if you were going further afield, we'd often use Sydney Airport to fly out. And in fact, we used to be able to go Med 1 from Sydney Airport, which meant the only person that could land before us or take off before us was the Queen. Now, I know we're now in the King's region, but that was the only person that could delay us. So we felt very, very special being able to do that.
Wow. Yeah, that definitely gives you a certain rank.
Completely. Now, the planes that we used in the airport weren't ours just for us, so you had to make sure they were available. I don't have that issue with Capital, thankfully, but it was great fun. It was a really, really good way of learning. You also had to think though as well about not just the distance and locations, but about conditions, air conditions, and also when I say air conditions, actually what I mean is weather. Because, if you were coming in, if there was a big storm coming in, it may not be appropriate to go up in a helicopter. If the mists were coming in, you may not be able to. So there was lots and lots of planning about what was the right way to travel. And that stuck with me over the last 20 years, because it isn't as easy as just going, well, this baby is in X and needs to go to Y. You need to think about all of those other issues as well. So as you can see, even though, I started 20 years ago, I've still got that passion. And when my team say to me, hey, I want to go and do an air transfer, I can't tell them it's not a good thing to do, because actually getting the right baby to the right place in the best time possible is definitely what we want to achieve.
Yeah, and whether that's rotary or fixed wing, or as you say, sometimes the ground ambulance is going to be the better option, because at least it might take a little bit longer, but you're going to get there.
Yeah.
Whereas, having a plane or a helicopter diverted because you thought you could make it and then the weather comes in and actually you can't, can adversely
Absolutely.
affect patient care.
I learned always to
It's
travel with I was going to say, I learned always to travel though with a spare toothbrush, because you
Yeah.
never knew when you might be sort of, you had to stay somewhere overnight.
Yes, that's very true. So along in your medical equipment bag is always a change of clothes as well.
Absolutely.
I think it's interesting what you were saying about how New South Wales, the geography of it was what kind of prompted the development of nets and the transfer system. And do you think that is that one of the trends that you're seeing in transfers, whether that's domestically in the UK or internationally as well, that might be indicative of wider trends in the medical sector where we're seeing centres of excellence, perhaps particularly for children and for neonates, that are further away from where the children are? So this need for transfers is actually increasing.
Yep, there is. And you're right. We have gone, 20 years ago, people would do a little bit of everything in their local areas. That is less common these days, and certainly within my day-to-day job, it's not unusual for us to fly out children for heart assessments for potential transfers to one of a few centres in the UK, whereas that might have been different 20 years ago.
Yeah.
Within Capital, we are seeing a huge increase in both international and domestic transfers. So looking at our numbers, we're doing roughly 70% more international repat than 2 years ago, and 30% more domestic movements.
Okay.
And that's really interesting. So in some ways you can, people are going to travel. They're going to travel when they're on holiday. And, the only way you're going to get back if you're in a far-flung country and you have a little baby is by air.
Yes.
But we are seeing, as I said, that increase in the domestic market as well. Again, parents traveling, delivering one end of the UK and needing to get back to the other end of the UK. And because we've now developed the expertise in air transfer, in the past we would have gone, oh, well, we're going to put these babies in a road ambulance for 6 to 8 hours. Whereas actually, because we're starting to talk to each other and saying, right, can we do? What is the best way for this family to travel? Also, it's not very comfortable for staff being in the back of an ambulance for 6 to 8 hours when we
Oh
could
gosh, no.
potentially, and it's a better use of time. We can actually perhaps do more than one transfer on a particular particular
Mhm.
day if we use our time wisely. But it's balancing that what is the best thing for the families and the baby as to what mode of transfer we go.
Do you think that, I mean, COVID obviously ruined travel for everybody, but particularly I think it made people who are potentially more at risk of an adverse event less likely to travel. That seems to have gone now. Even I've seen the reports saying the return of baby moons is a thing. Do you think that's partly what's driving the increase in neonates being born abroad?
I don't know if it's the change because I'm not because it's that hidden number. I don't know how many babies would have been born abroad, and we didn't ever hear anything about them because they were only transferred back to the UK when they were actually post term. I think what we're starting to see now is insurance companies and parents starting to say, actually, do we need to wait until this baby is fit to fly on a commercial flight without a medical escort? Or now, can we get them back to the UK sooner? And that's
Mhm.
something we are really, really keen to work with the sort of the agencies to say, actually, these babies don't need to stay there and wait, months and months and months and months and months away from home. You know, doing that can have devastating consequences for families, impacting on those families, their life, their mental well-being, and
Mhm.
bonding. I'm aware that, in some neonatal units, you can only visit your baby for a short period of time every day. Fathers sometimes can't visit more than once. Whereas in the UK, neonatal units have got open door policies. Parents are there day and night. So I think it's a more complicated thing. I think you're right. I think people are now going, I'm going to travel. That's great. But I do think as well, I'm hoping we're going to start to see let's get these babies back sooner than we would have perhaps before COVID, because there is a good and regulated and a system in place to try and get babies back.
Oh, absolutely. I mean, I think insurance companies, by their very nature, are risk averse, so that they're kind of always going to want to just say, let's wait until the 40 weeks is passed, and
Yeah,
then they'll be okay. But I think what's in the best interest of the patient and the family as well, like you're saying, has to be part of the discussion
absolutely.
that you're having with payers, whether that is the family or an insurance company as well.
Absolutely. And I think what we want to do at Capital is make sure that we've got that safe system, that well designed, well organized system in place. So if the need is there, that we can safely bring a baby and family back to a neonatal unit in the UK, where they
Sure.
can then have ongoing care. But also one of the big things for us is making sure that we can provide the right care and the ongoing care while we're doing that transfer.
So the right care and the ongoing care can, as you're saying, these babies can still be quite poorly but they can be transferred. When it comes to the right care, you need the right equipment.
Mm.
So what do you carry on board? I mean, obviously every mission, every patient is slightly different, but when it comes to sort of your core equipment, what do you use? What's essential? And also what is changing, what's developing now to allow you to provide better, more enhanced care for these tiny patients?
Funny when you say tiny, to me, tiny is anything under about 500 grams. Whereas
Oh,
So babies are lovely and but we have different levels of sort of care. So we can go with the all bells and all whistles. We have our dedicated neonatal incubator, which is
Mhm.
exactly the type of incubator you'd see if you walked into any of your neonatal units in the
Yeah.
UK. So it is a beautifully constructed, if I say box, but it's something that can provide
It's a nice
heat.
box, though. It's a nice
Yeah,
box.
it's a lovely box. It can provide heat. It can provide a strapping, almost like seatbelt. We can add on extra oxygen. We can add
Mhm.
on different types of oxygen. We can add on a special neonatal ventilator as well. So we can move babies who are needing full-on intensive care. We would
Right.
only do that if the baby's condition allowed us to do that.
Of
Because what
course.
we don't want is we don't want any risks. You've talked about insurance companies being risk averse. We are even more risk averse. So we need to know that this
True.
baby is suitable for transfer. So keeping baby warm, supporting breathing, securely strapping them in place, giving them any fluids or anything they need, any medicines they need. So we can do that. So we
Hmm.
have the sort of the all bells and all whistles. We have the add-ons as well. We can do things like blood testing, checking the blood sugar, making we're giving the right level of ventilation as well, because we've got special sort of machines to do that, handheld machines. But then we
Hmm.
have the other level as well. We have supplemental oxygen. When I say just, it's because it's very routine for us. But it might be
Yeah.
that, we're going on a commercial flight with a medical and a nursing escort. And in those cases, we wouldn't have the incubator. I think people would be looking at us and wondering where on earth we were going to put it. But we would be having our medical bags, our equipment, with things like, as I said, supplemental oxygen in case we needed to deliver that, saturation monitors, again, because we do know that babies might be very, very happily breathing in room air in their
Hmm.
neonatal unit, but if we go in a plane, that might be slightly different. So again, what we do is we triage the babies to make sure we are carrying the right level of support for them. So we can go up a level if we need to, but hopefully not.
Yeah. And as you say, actually, the taking them on board a commercial plane versus one of Capital's. So just to briefly say, what fleet do Capital operate? Fixed wing? What planes have they got?
So we've got a variety of ways we can fly. We have our own King Air 200 turboprops, so we can do the tool transfer with our own kit by our own team and our own aircraft. The other way we can do it is that we can use another partner's aircraft. So we can do something called platform, which is when we use the medical team and our kits on another aircraft, or we can use approved partners' jets. So different ways of travelling.
Okay, yeah. So what you would need for a commercial jet would be still be different than what you would need in one of Capital's jets.
Yeah, absolutely, absolutely. So, and again, this is when we are looking at a mission, planning exactly what kit we're going to need is so
Hmm.
important, because it's going to be different. Although a lot of it's going to be the same, it's going to be different for individual patients. And again, it's making sure you have that right kit, because unlike being on a neonatal unit, you can't go to the storeroom to pick up something you've forgotten. You got to make sure you got it with you.
In terms of the advancement, sort of what's changed when you first started treating neonates to now, what do you think's the best thing that's changed? Like the equipment that you've got?
I think we have much better neonatal incubators. I
Okay.
think keeping babies warm is the big thing.
Okay.
And I think incubator design has improved. We've got a really nice incubator. I won't say it's lightweight, because incubators are never lightweight, but it's lighter than it was. And the fact that we can strap things on that we need to as well. So we
Yeah.
have got a lightweight ventilator, which is great, because I've mentioned earlier, neonates can be tiny or they can be
Yeah.
actually turnish. So you've got to be able to move from, I'm not saying we would put a 500-gram baby in the air at this moment in time, but you might put a kilo baby, and then another baby might be 3.5 kilos. So you're looking at, it's a really wide range of weights. So we've got to be able to flex with what we've got as well. So the incubator is definitely always going to be my favorite. If we don't think the baby needs that highest level of support, we do have things called baby pods, which are fiberglass, sort of a different type of boxes, which are lighter, much lighter from a health and safety point of view as well. So they can be used as well. But I'm going to plump for the incubator if I had to take it to the desert island.
I think we've covered the topic quite comprehensively now. So thank you very much for your time. I've just got one more question for you, which is looking ahead to the future of neonatal transfers and neonatal medical care on the ground as well as in the air. What do you want to see? What are your hopes for these sort of vulnerable patients and also for the medical transport industry? How can it cater to these patients better?
I think everything comes down to communication. And I think almost like a streamlined platform, everybody knows what to do. So we often find out about patients abroad via very circuitous routes. And parents who perhaps have spoken to lots of people and not getting the answers they need, answers they want. And then eventually we find them, and that's grand. But it's trying to make things easier for everybody. So perhaps, educating the insurance companies to, actually, there is an easy way to do this or an easier way to do it. Yeah, and perhaps sharing good news stories, and what breaks my heart is the thought that there is a family out somewhere that is scared to death because they've got a baby that is receiving medical care, and that's really, really awful for them because they weren't expecting it. It was different to what they were expecting. They're far from home, and they've got no idea how to get back to where they came from. And actually, that shouldn't be their highest priority, their highest worry at the moment. Their highest worry should be their baby, but they're having to deal with everything else. And it would almost be lovely if there was like a magic sort of tick, that this is how it's all sorted out. And I'm definitely blue sky thinking, because we know that parents will go and have their babies any part of the world. So I can't educate every single neonatal unit in the world to know how to support these parents to get back to the UK. But we've got to be able to work together to make it easier, to take some of that worry away from these parents so they can concentrate on their baby.
Oh, that's a wonderful it's a really wonderful positive hope. And I think that working in the international arena, definitely I think that communication between medical professionals is absolutely essential, because as you say, there might not be this knowledge that actually there's a brilliant air medical infrastructure that works internationally seamlessly and safely to get these patients home.
Yeah.
So there are options, even for the neonates that seem too small or too sick. There's always options, right?
They're never too small, and we hopefully can move them when they're not too sick.
Oh, well, that's wonderful. Alex, thank you so much for your time. It's been really interesting talking to you today.
It's been really lovely talking to you as well. And I hope I've managed to convince you that neonatal intensive care is fabulous. And actually, we want to make sure that every baby, every family gets the highest standard of care. And that includes not just the medical stuff, but the holistic care close to home as well.
Absolutely. Well, it's good to know that there are teams out there that are doing just that. So thanks so much. And it's been great having you on Waypoint.
Bye.
Right, on that note, I think we'll end it there. Thank you so much again, Alex, for coming on the podcast. That's all for this episode. Don't forget, you can listen to new episodes every 2 weeks, all on your favourite podcast streaming platform. Until next time.